Hello, everyone. My name is Dr. Wilfredo De Jesus, and it's an honor for me to be part of this conference or virtual patient conference for HHT Canada. And thank you for the invitation to talk a little bit more about pediatric HHT care. I want to share something about me for those that are not related or they doesn't know about my background. My name is Dr. Wilfredo De Jesus Rojas. I'm a pediatrician, but also I'm a pediatric pulmonologist. I completed my fellowship at the University of Texas in Houston. And since then, I'm working in Puerto Rico. And also I'm part of the Poncel Science University, where we have a research laboratory, and we are the doctor for the Rare Pediatric Lung Institute in Puerto Rico. We are working with HHT patients in the past 4 years, and we already have an HHT pediatric clinics for patients with HHT in the island. So the goal of this presentation is to provide a review of the pediatric HHT and the clinical findings. We will provide an overview of the pediatric recommendations, including in the 2020 International HHT Guidelines. We also will review the use of the pediatric checklist in HHT, and that will be part of our conference, and I'm very happy to be with you. So let's talk a little bit more about HHT in general. So as most of you may know, HHT is a genetic disease, is considered an autosomal dominant disease with a prevalence of 1 in 5,000. This is a disease that affects vascular malformation. So the most common things that we may see in a patient with HHT is skin, mucosal, and organ telangiectasias or vascular malformation that usually occurs in the skin, the nose, GI tract, brain, lung, and liver are usually characteristic. Sometimes, specifically in areas where HHT is not well recognized as a disease, could be underdiagnosed. Patients with HHT in the United States usually are not aware that they have HHT. The same happened in Puerto Rico. Because sometimes that happens, there is a long delay in the diagnostic or the recognition of this disease that could last years to decades in order to get a proper diagnosis. So the most common symptom in HHT is epistaxis of nose bleedings. It worsens with age, thus the appearance of the typical telangiectasias. Usually the HHT is diagnosed clinically, and most of the information that we use right now is a group of questions that is called the Curaçao criteria. But also the genetic testing is very important, and it has been part of our diagnosis most recently, because we know that there's more and more mutation in different communities and countries, and that is also very important to be completed. The genetic testing is easily performed. Usually, if we identify a patient with HHT in a family, we can test other siblings, brothers and sisters, in order to check if the patient have HHT mutations as well. Of course, we always take in consideration the clinic of our patient. If the patient has also another symptoms like nose bleeding, vascular malformations, or telangiectasias. The criteria for HHT are known as the Curaçao criteria, are the same that we use in adults, but also we use it in pediatrics as well. The diagnosis of HHT is usually defined by some criteria. If you have more than 3 criteria, it's a definite diagnosis. For example, nose bleeding is one of the most important ones. Spontaneous recurrent nosebleeds. Also telangiectasias multiples that are specifically in lips, oral cavity, or mouth, fingers, and nose, and also if there is any involvement of the malformations inside the human body, for example, in the gastrointestinal tract, in the lungs, in the liver, or in the brain. Those are called cerebral or spinal arteriovenous malformations. In terms of family history, we usually ask for if there is any fertility relative with HHT, and also we order genetic testing to confirm the genetic diagnosis and understand more about the mutations. Usually these criteria have been implemented in adults, but also it has been evaluated in pediatrics. And so the applicability of these criteria, it has been evaluated in the pediatric population. So the conclusion of this article said that this study evaluated the Kurasa criteria in HHT population, and in those that are between 0 and 21-year-old that have one criteria or two criteria, the genetic testing is preferred for diagnosis. That's why we do genetic testing as well. But also the Curaçao criteria appear to be reliable to diagnose HHT in children and adolescents who meet 3 or 4 of the criteria that we already have discussed. This study was completed, and the overall sensitivity and specificity of the Curaçao criteria in pediatrics was 68% and 98%. So it's very specific in order to diagnose HHT, but as well, we always confirm with the genetic testing. Now the genetic testing is quite available in different countries and it's not as expensive as in the past. So we would like to know both the characteristic that our patient has, but also we want to understand what the genetic basis of our patients. That probably it will be very important in the future in order to see if there is any therapeutic medicine or treatment that we can use specifically for those patients that have genetic mutations. So let's talk a little bit about the manifestations. Manifestations are, for example, telangiectasias, or blood vessels are all dilated. For example, in 95% of patients with HHT will have telangiectasias before 40-year-old, and only 30% before 20 years. So that is probably a problem, because in children, sometimes the lesions are not as quite visible. Sometimes we see an adult, like in this picture here, that have a lot of these tiny red spots that are telangiectasias in the lips, but also in kids, it could be just one. And sometimes patients think that only one may not be a telangiectasia, maybe is that they bite their lips, and sometimes they confuse this with other diseases. But those telangiectasias are usually appear in face, lips, ear, as I mentioned before. In children, typically, skin findings may not be present or maybe missed by examiner, as you see, because sometimes it's very, very mild, okay? As compared with the adults, of course. So this is another example. In an adult, you can see all these lesions, but then in a pediatric patient or a child or an adolescent, it's just these tiny tongue telangiectasias that you can see here. The same thing happens when you look at the fingers. You have to be very careful, because sometimes between fingers you can see these tiny red spots that are more common in adults, but in pediatrics it's just 1 or 2. No bliss also is one of the symptoms. In adults, 95% of them will have nose bleeding by age 40. And this is one of the most common symptoms that they report. May begin in infancy. Sometimes it's very profuse. And that may occur daily or never. But in children, usually around 80 to 90%, they will have at least a nosebleeds by age 21-year-old. Only 33% by age 10. So it is getting worse over time or more frequent. That's something that we also have to take into consideration. In terms of the pulmonary arteriovenous malformation, those are the telangiectasias that occurs inside the lungs. In adults, is usually 55% of the time we have pulmonary arteriovenous malformation. 60% may have more than one, 90% are just simple pulmonary arteriovenous malformation. And you may think about what are the symptoms for pulmonary arteriovenous malformation? Sometimes it's not symptoms at all. Sometimes it's episodes of bluish discoloration of the skin. Sometimes it's exercise intolerance. You may not be able to do all the activities that you have been doing in the past. Or your child. Sometimes is coughing with blood. Sometimes is low oxygen. Pulmonary hypertension or inclusive headaches could be a manifestation of pulmonary arteriovenous malformation. In children, as compared with adults, 20% may be asymptomatic. So this is something that is unrecognized in the pediatric population. And sometimes exercise intolerance may be mistaken as asthma. And it's very common because in Puerto Rico, there is a lot of people with asthma as well in other countries. So patients may feel only fatigue with activity, and that could be a confounder between asthma and a pulmonary arteriovenous malformation. So we have to take that into consideration when we are evaluating patients with HHT as well. And this is a picture of what we have been talking about. There is 90% chance that a pulmonary arteriovenous malformation could be simple. That is just a connection, a simple connection between the pulmonary artery and the pulmonary veins. But also 10% could be also a complex arteriovenous malformation that involves more than one branch of the pulmonary arteries. This is an example when we evaluate a patients with HHT in Puerto Rico, we detect a pulmonary arteriovenous malformation. This is something that we can do. It's a chest CT, it's a picture of your lungs that show an area that is more white in this area here, right? So that is the pulmonary arteriovenous malformation. Is an area that there is a connection that should not be there, and that make you have all the symptoms that we already described. That pulmonary arteriovenous malformation could have a treatment. So in that case, what we do is we refer the patient to a pediatric cardiologist. This is a pediatric cardiologist with an expertise in interventional cardiology. And the cardiology could provide a treatment for the pulmonary arteriovenous malformation. In this case, is what we call an embolization. We use procedure to try to fix all the pulmonary arteriovenous malformation in the patient. The same thing happens with arteriovenous malformation that occurs in the brain. This is a picture of an arteriovenous malformation that occurred in a child. It's not common to have an arteriovenous malformation in a pediatric patient, but it's important to evaluate the patient for those malformations as well. In adults, it occurs in 10.4%. They may have vascular malformations. In children, there is some report that said it is 25%, but sometimes it's from 9 to 25%. So we need more research in order to understand the time where patients with HHT are presenting with brain arteriovenous malformations during the pediatric era. The treatment as well is surgery, embolization, and radiotherapy. Those are potential treatments for patients with HHT. So now we will discuss the second international HHT guidelines. Those are the guidelines that help the doctors in order to understand and diagnose and treat patients with HHT. Specifically, this section here that we'll be discussing is for pediatric care. So these are the pediatric care guidelines. Those are 6 recommendations. First ever HHT guidance for children, spanning from newborn to age 18. And the recommendations are related to diagnosis of HHT, screening and treatment for pulmonary arteriovenous malformations, and also screening and treatment from brain vascular malformation. So let's start. So the pediatric care recommendation number 1, it says that the expert panel advised that diagnostic genetic testing be offered for asymptomatic children with a parent with HHT. So that means that every patient we evaluate and the parent has HHT, we should test the children because there is a probability that the child also have a genetic mutation that we can diagnose this patient early enough, even without symptoms. So this is a 96 agreement and 94 quality of evidence high, and strength of recommendation is strong. So every time in our clinics that we have a parent with HHT, even a patient has no symptoms, with pediatric patients with no symptoms, we screen them using genetic testing. And in order to complete this, we offer them a saliva test. And you can do it on blood, saliva, or additional fluids, but saliva and blood are pretty well recognized as a genetic testing that could provide us the mutations that are associated with one of the 6 genes. And these 6 genes are the currently known genes that have been related with hereditary hemorrhagic telangiectasia. In Puerto Rico, for example, the most common one is endoglin, as well, and other countries as well. But also we have patients with ACVR1 and also another SMAD4. So the pediatric care recommendation number 2 says that the expert panel recommend a screening for pulmonary arteriovenous malformation in asymptomatic children with HHT or at risk for HHT at the time of presentation and diagnosis. And this is a quality of evidence of 94% and a strength of recommendation of 94%. And this is something that we implement in our clinics as well. As at the time of we complete the genetics testing, we evaluate our patient for pulmonary arteriovenous malformation. And the way we do that is when you have a suspicious pulmonary arteriovenous malformation or a patient at high risk, we order an chest X-ray and an oxygen assessment. That means that you can measure the pulse oximeter of the finger. And then we order a contrast echocardiography, and this is what we call commonly as a bubble echo. And depending if the result of the bubble echo, then we may consider to do a chest CT, a computed tomography, or an image of your child lungs. So screening, as I said, may be performed with either chest X-ray or pulse oximeter or a transthoracic contrast echocardiography. This is the bubble echo. Screening with CT is not recommended because we also want to make sure that the pediatric patient doesn't get too much radiation. So the bubble echo is a sonogram, so it doesn't use radiation. So we try to use it as much as we can before we use additional imaging that could potentially leads to problems in the future because of radiation. Okay, perfect. So let's review the pediatric care recommendation number 3. So the expert panel now recommend that large pulmonary arteriovenous malformation and pulmonary AVMs associated with reduced oxygen saturation may be treated in children to avoid serious complications. And that is an agreement with 98% for both quality of evidence moderate, but also strength of recommendation strong. So that is very important. And the clinical consideration for that is that pulmonary arteriovenous malformation with feeding arteries more than 3 millimeters in diameter are suitable for embolotherapy. So that means that patients with a pulmonary arteriovenous malformation that have more than 3 may need additional procedures, and that is usually performed, as I recommended before, by a pediatric cardiologist or an interventional medical doctor. So the pediatric care recommendation number 4 is that the expert panel recommend repeated pulmonary AVM screening in asymptomatic children with HHT or at risk of for HHT, typically at 5-year interval. So this is a quality of evidence that is classified as low with an agreement of 92%, and also a strength of recommendation of 86%. The clinical considerations is like typically negative screening is repeated every 5 years. In children with indeterminate or borderline screening results, either base or imaging or oximetry, a screening should be repeated sooner. Okay, perfect. So let's continue talking about our pediatric recommendation care number 5. So in this pediatric recommendation, the expert panel recommend a screening for brain vascular malformation in asymptomatic children with HHT or at risk of HHT at the time of presentation or diagnosis. The quality of evidence for this is 86%, and the strength of recommendation is as well 86%. So they based this recommendation in a case series that demonstrated risk of intracranial hemorrhage for brain vascular malformation in children. And they suggest as MRI as a sensitive screening test and beneficial for surgical endovascular management with also a significant risk. So, and those patients that we evaluate with HHT at the time of diagnosis, they will get a bubble echo for the pulmonary arteriovenous malformation, but also for the brain vascular malformations, we also recommend to do the first-line screening for it will be an MRI, and it's a contrast enhanced that is more sensitive to identify brain vascular malformation and determine the subtype and risk factors for this hemorrhage. So typically in pediatrics, we get MRI under sedation and with the guidance of an anesthesia doctor. So that is very important as well, that we understand that MRI is also part of the evaluation at baseline at the time of diagnosis as the pediatric care's recommendations. In terms of the recommendation number 6, the expert panel recommend that brain MRI, that brain vascular malformation with high-risk features should be treated, and that is an agreement of 100%. And the clinical consideration for that is that given the need to balance natural history risk with treatment risk, children with HHT who have brain vascular malformation should be referred to a center with multidisciplinary expertise in neurovascular disease management. So, for example, in Puerto Rico, after I diagnosed a patient with HHT, we completed an MRI, and if I found something wrong with the MRI of my patient, I would recommend to move the patient to the capital and complete a multidisciplinary expertise evaluation with a neurovascular surgeon. And this is also very important in order to avoid long-term complications. So this table here is a summary of the recommendations as well, and the expert panel recommendation, and the we already discussed, and the quality of evidence and the strength of recommendation. And so 1 to 6. So this is the summary that we already discussed, and I'm happy to inform to you that in the future also we may have to review the different recommendations with the data that we get over time. As soon as we do more research in pediatrics, these guidelines may be needed to be updated in the future, as well as the management and the treatment that we already use. This slide here is focused on the resources. For example, this is the HHT guidelines.org is one of the links that as a parents is available to provide information about your HHT disease and how you can download all the information that they have on the web page. You also could share these guidelines with other doctors, colleagues, and patients. And also one thing that is very important is that you can download and share the checklist. And that's the best part of this conference, because as a parent, sometimes we have like too many things in our mind that we don't really understand what is the next step in my child guideline or my child care. So this is intended for both the patient, but as well for the medical doctor. Is available as there is a general checklist, but also there is a checklist for specifically different problems. For example, this is a checklist. The one that you see here is for my child HHT care checklist, and this helps us to understand the role of the guideline, how I should manage my disease, or how I should manage the disease of my patient, or also how as a parent I should go to my doctor and ask specific questions about the HHT management of my child. So you can do you can go to this website and you can download all the full collection of the checklists that they have available specifically for your child HHT. I will go ahead and put the date on that page, the child name, and also the ask every questions I have here, every statement, check if I already have that. For example, one of the things is my child has a parent with HHT and we don't know if my child is affected. Checklist, talk to my child, doctor about genetic testing for my child. So all these are very important topics that you have to discuss with your pediatrician, and also as well as with your pediatric pulmonologist doctor or cardiologist in case you have one. Also, this is more for children, but also there is one for teenagers. Another checklist in order for them to empower themselves about HHT and how to treat them and follow the recommendations. The same thing also as you complete, you can do this also online, that you can check all the check marks. For example, we already spoke about the first one, but the second one is my child has HHT or may have HHT. So if the diagnosis has been ruled out, so should we ask the doctor about lung arterial malformation? Should we ask the doctor about vascular malformation of the brain? If my child has a pulmonary malformation, should I consider preventive treatment? Should I talk with my child dentist about any medication that I need to provide to them? So all those questions are very, very important in order to be addressed, and also to have this in your mind, right? Because every time we go to the doctor, always we forget. I mean, sometimes we forget about the question that we have to ask, but with these guidelines and checklists, that will give you power in order to make sure that you already have everything you need. Okay, perfect. So that is very important, and I'm very happy to take any questions that you may have. My name again is Dr. Wilfredo De Jesus. I'm a board certified pediatrician pulmonologist in Puerto Rico, and I want to say thank you so much for be connected with me today. I hope these checklists and guidelines make you sense and make you think more about how I should improve my child HHT care. So if you have any question, you can write me an email. My email is wdejesus@psm.edu. And I'm very happy to connect with you in the future. I will say that this conference was adopted from Cure HHT with permission of Dr. Andrew White and Dr. Adrian Hamill. Again, thank you for HHT Canada for the invitation. Thank you so much.